So may I request Dr. Vishwanathan? He would be talking on ABG interpretation.
Good afternoon, chairpersons, senior faculty members, and all the postgraduates, one and all. In the 15 minutes time which is allotted to me, I will try to cover the concepts related to acid balance and then try to simplify the concepts. As we know that arterial blood gas analysis gives us vital information regarding the pH, PaO2, PCO2 bicarbonate. So by looking at pH, PaO2 and the PCO2 bicarbonate, we get vital information regarding the acid-base balance, oxygenation and ventilation. So when we do this ABG, we should do it with proper precautions. We should know the normal values and we should also know the expected compensation which can occur in different values in different settings. So let us briefly review the physiology before going to the actual interpretation of the acid-base balance. In the body, two different types of acids are produced. One is volatile type of acid and the second one is the non-volatile type of acids. In the volatile type of acid, it's carbon dioxide, it's 150,000 to 20,000 millivolts of carbon dioxide are produced per day because of metabolism of carbohydrates and fats. And because of the metabolism of the sulfur-containing amino acids, cysteine and methionine, we have non-volatile acids which are sulfuric acid, phosphoric acid, uric acid, and some like keto acids which can occur in diabetic ketoacidosis or lactic acidosis. So why are all these important? Because when we have increased acid load in the body, the pH changes. It is very important to keep the pH in the normal range, because when the pH comes out of the normal range, it prevents the enzymatic function, it prevents the hormones from binding to its receptor, it prevents the membrane function, and different functions of the different metabolisms are impaired because of the impairment of the pH. So how is it that the body keeps the pH in very normal range? Actually, we have three different systems which can keep the pH in the normal range. One is the buffer system, and the second is the lungs, the respiratory system, and the third one is the kidneys. Lungs and the kidneys function in coordination with each other. When lung is the abnormal organ causing respiratory acidosis, the kidney tries to compensate by absorbing more bicarbonate. When kidney is the culprit causing metabolic acidosis, the lungs try to eliminate the CO2, thereby maintaining the balance and maintaining the pH. So they work in coordination, the kidneys and the lungs, in maintaining this acid-base balance. So what does this buffers do? Buffer is any substance which maintains the arterial pH in the normal range when there is any disturbance in the pH. So the main buffer which we have in the extracellular fluid is the bicarbonate system. What it does is it accepts the H plus which is released from the acids, it converts into bicarbonic acid, and then it splits into H plus and bicarbonate. The H plus is excreted to the kidneys and the kidney tries to reabsorb the bicarbonate. And in the intracellular compartment, we have phosphate and proteins which can cause buffering of the H plus ion, which is released from the acids. So let us look at how pH is calculated. Then we'll have important concepts related to the compensation and all these things. This is the bicarbonate, so that the fraction remains constant and the H plus concentration is maintained constantly. So similarly in respiratory alkalosis, PCO2 decreases, and we know that the bicarbonate concentration also decreases. The fraction is constant, the H plus is maintained constantly. So similarly in metabolic alkalosis, bicarbonate concentration rises and the PCO2 concentration rises. So this will help us in understanding the concept of compensation in my further slides. This concept of increasing CO2 and increasing bicarbonate. And these buffers are present in a limited concentration in the blood. They are about 12 to 15 milliequivalents per liter. In cases of severe acidosis, this will not be sufficient to buffer the acid load which is there in the body. So what does the body do? It releases the calcium salts which are present in the bone to buffer the acid load. This scenario occurs in patients with chronic kidney disease. So it releases the bone and it causes renal osteodystrophy. So the kidneys tries to excrete this acid load and also tries to restore the buffer so that it can be used for further acid and base insults. The carbon dioxide is produced because of the metabolism. So in the tissues, it combines with the H2O because of the carbonic anhydrase enzyme, and it splits into bicarbonate and H+. H+ is taken by the hemoglobin, and the bicarbonate is transported in the plasma to the lungs. Again in the lungs, the reaction occurs in the reverse direction because the lungs are always eliminating the CO2. What does the body do? It tries to carry the reaction in the reverse direction. So H plus HCO3 combine, again they form H2CO3, and the CO2 and H2 are formed, and CO2 is eliminated through the lungs. This is what happens in the lungs, and this direction will happen in the tissue. So the respiratory centers which are present in the brain will try to respond to the pH concentrations which are present in the extracellular fluid and the CSF, and they will subsequently increase the respiratory rate to eliminate the acid load. And what is the function of the kidneys in maintaining the pH? So one is they eliminate the H plus load, and the other thing is they will cause reabsorption of the bicarbonate, and they will also generate bicarbonate. So this H plus secretion in the kidneys is done mainly predominantly in the form of ammonium. The ammonia is produced from the glutamine. It produces ammonia glutamine in the renal tubular cells. It diffuses into the tubular cells. It binds H plus and forms NH4 plus. And a little amount of free H plus is also excreted in the kidneys. And the bicarbonate absorption occurs predominantly in the proximal tubules, and 10% of the bicarbonate absorption occurs in the distal tubule. So let us understand basic definitions. Acidemia means that there is reduction in the arterial pH below the normal levels. The normal level of the pH is 7.36 to 7.44. Different books give different reference ranges. Some books give reference ranges 7.35 to 7.44, but most of them say that any pH less than 7.36 is acidosis, that is acidemia, and any pH more than 7.44 is alkalemia. So what is acidosis and alkalosis then? Exposure of the body to acid load is called as acidosis. It is not necessary that all patients with acidosis will have acidemia. Sometimes what happens is in the combined disorders, suppose if there is acidosis in conjunction with alkalosis, what it does is acidosis increases the H plus load in the body, and the alkalosis decreases the H plus load in the body. So they will balance each other, and the result will be that the pH will be normal. So it is not necessary that all patients with acidosis will have acidic pH. They can have normal pH as well. And what is this concept of compensation? Whenever there is any change in the acid base in the body, the kidneys and the respiratory system try to compensate and bring the pH towards normal. So this compensation is always not up to the full extent. As I told you, the kidneys compensate when the lungs are abnormal, and the lungs compensate when the kidneys are abnormal. So when the kidney is failing, so the kidney cannot compensate in patients with respiratory acidosis. Similarly, when the lung is failing, the kidney cannot, when the lung is failing, the lung cannot compensate in patients with renal failure. So these are the basic things which occur in any patient with different acid-base disturbances. So in all acidosis, we have increase in H+, the metabolic acidosis, respiratory acidosis, alkalosis decrease in H+. So the pH will be decreased in metabolic and respiratory acidosis. The respiratory and metabolic alkalosis, the pH will be increased. So the bicarbonate will be predominantly changed in metabolic component. In metabolic acidosis, it is decreased. In metabolic alkalosis, it's increased. And in the respiratory acidosis, PCO2 is increased, and in the alkalosis, PCO2 is decreased. So compensatorily, when bicarbonate decreases, PCO2 decreases. They both move in same direction, the PCO2 and the bicarbonate. So let us look at how much compensation occurs in each acid-base disturbance. In the metabolic acidosis, with PCO2 decrease of 1.3 mmHg, the bicarbonate decreases by 1 ml, 1 milliequivalent per liter. And in the metabolic alkalosis, with each 0.7 mmHg increase in the PCO2, the bicarbonate increases by 1 milliequivalent. And in the respiratory acidosis, when the PCO2 increases by 10 mmHg, the bicarbonate rises by 1. And in the chronic form of respiratory acidosis, which usually takes 48 hours, when PCO2 increases by 10, the bicarbonate rises by 4 milliequivalents. So in the respiratory alkalosis, acute and the chronic, it will be 2 and 5. So a simple tip to remember this is that when it increases little bit, 1 and 4, but when it decreases, it increases, when it decreases more actually, 2 and 5. This is a simple tip to remember the compensation which can occur in different disturbances. So before going to the interpretation, we should also understand the concept of anion gap. We have two different types of acidosis. One is the high anion gap acidosis, and the other form of acidosis is normal anion gap acidosis. What does anion gap mean? Basically, it means that it represents the unmeasured anions in the blood. Unmeasured meaning to say that these are not routinely measured during our routine ABG analysis. And how does these anions come? We have different organic acids in the body like lactic acid, keto acids, sulfuric acid. What these acids will do is they will dissociate into H plus and an anion. So this H plus is the thing which is causing acidosis, but anion is a bystander. It just tells us that there is acidosis, and it tells us that it is the cause for the acidosis. So when we have this anion gap, it is basically based on the principle of electron neutrality. It means that the total number of serum cations is equivalent to that of the total number of anions which are present in the body. So what are the predominant cations which are present in the body? Sodium is the predominant cation which is present in the body, and the other cations being potassium, calcium and magnesium, which are present in the small quantities. And the total serum anions, if you look at it, the predominant anions in the blood are bicarbonate and chloride, and the other small anions are phosphorus, protein and organic acid. So if you rewrite it, these small cations can be written as unmeasured cations, which are and the small amount of anions which are present in the body can be rewritten as unmeasured anions. So it is sodium plus unmeasured cations is equal to bicarbonate plus chloride plus unmeasured anions, which represents phosphate, protein and organic acid. So if you bring these two to this side, sodium minus the sum of bicarbonate plus chloride will give the difference between unmeasured anions and the unmeasured cations. So though the term indicates anion gap, basically it measures the difference between the unmeasured anions and the unmeasured cations. So the predominant unmeasured anion is the albumin, and the predominant unmeasured cations are the calcium and the potassium. Previously the value of anion gap was considered as 12 plus or minus 4, but because of the changes in the way the electrolytes are measured, the current levels of anion gap is 8 plus or minus 4 milliequivalent per liter. So we should know that there can be variations in the anion gap. It can change in each individual, and sometimes the different labs will have different standards. Some lab will have standard of sodium say of 130 instead of having 135. So according to the lab, the anion gap varies, and the individual can have variations in the anion gap. And as I told you that albumin is the most important unmeasured anion. The hypoalbuminemia leads to falsely low anion gap levels. Similarly, hypercalcemia will lead to false low anion gap. So we should understand the concept of corrected anion gap. It indicates that with every 1 gram decrease in the albumin, the anion gap should be increased by 2.5, because the hypoalbuminemia falsely leads to low anion gap. So for every 1 gram decrease in albumin, we have to increase the anion gap by 2.5. So this patient has an anion gap of 10, and the albumin was 2 grams. So if the albumin has decreased by 2 grams, from 4 to 2 grams, so the corrected anion gap will be 15. Suppose if we consider this anion gap, we will say that this patient is having normal anion gap. He is not having acidosis. But if we correct it for the albumin level, he is having a high anion gap acidosis. So what is this concept of delta anion gap and delta bicarbonate? So suppose there is increase of anion gap by 1 millimole, the bicarbonate will also decrease by 1 millimole. What happens is the anion will release the H plus ion, and the H plus is accepted by the bicarbonate. So for 1 millimole increase in the anion, the bicarbonate decreases by 1 millimole. So always the anion gap, delta anion gap, that is the change in anion gap, should be equivalent to the delta bicarbonate value. Suppose if the delta anion gap and delta bicarbonate are not equal, it indicates a mixed disorder. So this was a patient who was having a delta anion gap of 18. Suppose his anion gap was 18 and he had a change of anion gap from 10 to 18. So the delta anion gap is 8. So we expect the bicarbonate to come down by at least 8 millimoles. But this patient's bicarbonate was 20. It has decreased from 24 to 20, meaning to say that it has decreased by only 4 millimoles per liter. So he had concomitant metabolic alkalosis, which has prevented his bicarbonate from coming down. So this delta anion gap and delta bicarbonate concept gives us information regarding the mixed acid-base disorders. And I'll skip this slide. This is regarding the assessment of oxygenation. The normal values of PaO2 are more than 80 mmHg, and at 60 years of age, usually you have a PaO2 of 80 mmHg. And with each increasing year, the PaO2 decreases by 1 mmHg. So at 70 years, it is 70, 80 years, 60, and 90, it is 50. And most of the patients who require ABG are hypoxemic. So we did not remove the patient from oxygen to just do an ABG. The simple rule of concept is that if the patient's PaO2 is less than 5 times the FiO2, the patient is hypoxemic on room air. These are the expected levels of PaO2 on FiO2 of 30%, 40, 50, 70, and 100. So if the patient is having a PaO2 less than this, then the patient is hypoxemic on room air. So detailed interpretation of the ABG requires the knowledge regarding the normal parameters. So I'm sure that all of you are aware of the normal values. Okay. So when you are doing ABG interpretation, the first thing you should do is whether it is acidosis or alkalosis. When the pH is less than 7.36, it's acidosis. More than 7.4, it is alkalosis. And once you are very sure whether it is acidosis or alkalosis, then we have to decide whether it is respiratory or metabolic. If the CO2 is the culprit, then it is respiratory component. If bicarbonate is the culprit, is the metabolic acidosis or metabolic alkalosis. So you have to decide which is this. Depending on the scenario, we'll get to know whether it's an acute acidosis or a chronic respiratory acidosis. And we have to calculate whether the compensation is complete or not, the respiratory as well as metabolic compensation. And in the metabolic acidosis, we have to calculate if it is an high anion gap acidosis or a normal anion gap acidosis. And the concept of delta anion gap and delta bicarbonate. So the important thing is that when you take an ABG, you have to send it to the lab immediately, because the consumption of oxygen and carbon dioxide continues even after taking the ABG. So they will give you falsely low values of PaO2 and falsely high values of PCO2. And the syringe should be completely flushed of the heparin, because if the heparin is still there in the syringe, it leads to faulty values of bicarbonate as well as the PaCO2. And there should not be air bubbles. Air bubbles lead to falsely elevation of PaO2 and decrease in the CO2 levels. So let us look at some case scenarios. A patient has a 67-year-old female. She had underwent hip fracture surgery. On the post-op day 2, the patient was tachypneic and the saturation on room air was 80%. The pH was 7.46 and the PaO2 was 50, PCO2 30, bicarbonate 20. Any interpretation in the post-graduations? What type of disorder is it? Acidosis or alkalosis? This is alkalosis, respiratory alkalosis. So is the compensation correct? Is acute, because the patient had 1 day history of breathlessness, so it is an acute respiratory alkalosis. So what do you think will be the compensation? So for every 10 decrease in carbon dioxide, the bicarbonate should reduce by 1 millimole. So this patient has compensated respiratory acidosis, and the hypoxemia was moderate, because the PaO2 level was 50 mmHg. And the second case scenario, known case of polymyositis and immunosuppression. These are the ABG parameters. Can anybody tell what is the metabolic disturbance which is going on? Alkalosis, acidosis? 7.45, it is alkalosis. Fine. So is it metabolic or respiratory alkalosis? Look at the PaCO2 values and the bicarbonate values. It's metabolic alkalosis. Basically, bicarbonate is increased. So, is it compensated? And if so, what is it? Is it a simple disorder or a mixed disorder? Simple disorder is one acid-base disturbance, and mixed disorder is basically a combination of two things. Just this slide will be the last thing. So the expected PSCO2 will be the 44 mmHg with this bicarbonate level of 31. But this patient had an PCO2 of 49, meaning to say that this patient had respiratory acidosis, concomitant respiratory acidosis because of her muscle weakness actually, because of polymyositis. So this was a mixed disorder, fine. So this, I'll skip my last slide. I welcome any questions.